All, welcome to my channel. Today we are discussing regarding the mechanism of action of oral hypoglycemic agents. I've seen some questions regarding the same, and it has been a little bit intriguing, and we often forget which drug comes under which class and things like that. So I thought I'll dedicate this video to discuss more regarding the same. So oral hypoglycemic agents, they are classified under different categories. First, we'll identify the class, and then we'll try and understand more about each of the drug and how it is acting in the in our body, how it is controlling diabetes. So there are some drugs which can increase the insulin sensitivity. So it cannot alter the level of insulin in our body, but it can increase the insulin sensitivity. So it is likely to be useful in type 2 diabetes where there is insulin resistance. Those are mainly biguanides, which includes metformin, the commonly used drug, and thiazolidinedione, which is the newer drug called pioglitazone. So these two classes of drugs increase insulin sensitivity. They do not alter the insulin levels. But there are some drugs which can increase the insulin secretion, and they are called insulin secretagogues, or they are helping to increase the secretion of insulin. So usually how does insulin get secreted from the beta cells of pancreas? So there are agents which can act on the ATP sensitive potassium channel. One of the prime example of an insulin secretagogue is our glucose, which is happening inside our body. So glucose, when there is a spike of glucose in the blood, it can increase the insulin secretion, or insulin the already produced insulin will be released into the blood. So how does that happen? The glucose can act on the ATP sensitive potassium channel, which closes the potassium channel so that the beta cell membrane gets depolarized. Thereby the calcium channels get opened, so there is calcium influx. So just understand that it is acting on the ATP sensitive potassium channel and it is getting depolarized. So there is calcium influx, which leads to the exocytosis of insulin. So that is how insulin is normally secreted from the beta cell. So there are some agents which can act like an insulin secretagogue. The main examples are sulfonylureas and meglitinides. Sulfonylureas includes glimepiride, glibenclamide, glyclazide. And meglitinides include natiglenide and repaglinide. So these two classes are insulin secretagogues. Okay, sulfonylureas and meglitinides. So as they can increase the insulin secretion, they can cause hypoglycemia. So these drugs are prone for hypoglycemia, whereas our metformin cannot alter insulin levels. It is only, so as such it does not cause hypoglycemia. Now we have alpha glucosidase inhibitor, another class of drug called alpha glucosidase inhibitor. What is that doing? So starch is broken down by the alpha glucosidase enzyme. So the alpha glucosidase inhibitor, what does it do? It prolongs the breakdown process. So there is no rapid spike in glucose. So it is slowing down that process, and the class includes acarbose, miglitol, and voglibose. Okay, and before we come to another class of drug, we need to know what is an incretin effect. So far we have seen insulin sensitizing agents, the drugs that can increase the insulin sensitivity, the drugs that can act as insulin secretagogues, and we've also seen alpha glucosidase inhibitor. Now there is something called incretin effect. Incretin effect is the glucose in the stomach can stimulate the secretion of insulin. Okay, so the incretins are the already, inside a body there are incretins like GLP-1 and GIP. So when there is glucose in the stomach, the incretins are released like GLP-1 and GIP, gastroactive intestinal peptide, and GLP-1. So that can help in secretion of insulin. And these things like GLP-1 and GIP are degraded by DPP-4. So we have two classes of drugs. One are GLP-1 analog and GIP analog, and the other one is DPP-4 inhibitor. Both are acting based on the principle of incretin effect, which is, in simpler terms, it means glucose in stomach can stimulate secretion of insulin by uh, production of incretins like GLP-1 and GIP. So GLP-1 and GIP agonists are dulaglutide, semaglutide, exenatide, and liraglutide. Okay, glutides. GLP-1 and GIP agonists are dulaglutide, semaglutide, exenatide, and liraglutide. And DPP-4 inhibitor, which can uh, prevent the breakdown of this GLP-1 and GIP, is our gliptins, sitagliptin. Okay, gliptins, usually used as sitagliptin. Okay. Then, just like incretin effect, we have another effect called amylin effect. Amylin is something that is co-secreted with insulin, and this amylin can inhibit glucagon. So, glucagon is a hormone which is antagonistic to insulin. So, this amylin can inhibit glucagon, so it can accentuate or help the action of insulin. It is not acting directly in the insulin pathway or in the glucose metabolism. It is inhibiting glucagon, thereby helping insulin. It is not altering the levels of insulin. So amylin is co-secreted with insulin, and that can inhibit glucagon. So we have drugs that are amylin agonist, which is called pramlintide. Okay, so far we have seen the insulin secretagogues, drugs that can sensitize the insulin, alpha glucosidase inhibitors. We have seen incretin effect, and two classes of drugs, GLP-1 and GIP agonist and DPP-4 inhibitors, and amylin effect and amylin agonist. Then, so far we have seen drugs that are acting on the beta cell or on the receptors or inside the stomach or GIT or small intestine. But apart from all that, there is another class of drug which is acting in the kidney. So it is acting at the level of reabsorption. So that SGLT2 inhibitor, so SGLT2 receptors are present in the kidneys. So they inhibit reabsorption of excess glucose from PCT via sodium glucose co-transporter 2. So usually what happens is we are reabsorbing our glucose from the PCT. So we are inhibiting that at the level of kidney. So that is called SGLT2 inhibitor. That is our gliflozin, dapagliflozin. Okay, this is now commonly used especially for CKD patients and all, and has proven cardiac benefits. So this is a dapagliflozin, SGLT2 inhibitor, which is acting at the level of kidneys, which is preventing reabsorption of excess glucose from the PCT. Okay, so this is in short, in summary, what is happening. So starch is broken down to glucose by alpha glucosidase. So we have drugs which is inhibiting the alpha glucosidase inhibitor. Okay, now so we have GLP-1 and GIP agonist, and GLP-1 and GIP are usually degraded by DPP-4. So we have another class of drug called DPP-4 inhibitors. Then usually the insulin is secreted from the beta cell of pancreas. So we have an incretin effect, where incretin effect is this GLP-1 and GIP acting on the beta cells to produce insulin. So we have two classes, GLP-1 GIP agonist and DPP-4 inhibitors. Then there is an amylin effect. Amylin is co-secreted with insulin, which can stimulate the production, inhibit the production of glucagon. So glucagon is an anti-insulin-like hormone, so it augments the action of insulin. So we have pramlintide, amylin agonist, which is pramlintide. Then we have at the level of reabsorption of glucose, SGLT2 inhibitors, which are preventing the excess reabsorption of glucose from the PCT of the kidney. Okay, so these are the classes of drug: alpha glucosidase inhibitors like voglibose, acarbose, GLP-1 and GIP agonist, DPP-4 inhibitors. We have amylin agonist, that is pramlintide. We have insulin secretagogues, which are sulfonylureas, and we have drugs that can increase the insulin sensitivity, that is are biguanides like metformin, and drugs that can inhibit the action of SGLT2, thereby preventing the excess reabsorption, which is our dapagliflozin, and it has a proven cardiac benefit. So that's all for today. Thank you for listening. Keep watching and following the channel for more updates on MRCP.